present here. I don't see anyone else. So we'll start on time. And the first free paper session is on diabetic retinopathy and medical retina. And there are a lot of people who are going to chair the session, but they're running a little late. So we will start with the first free paper, which will be presented by Dr. Shivani. And the paper is on spot urine albumin protein is a molecular biomarker for severity of diabetic retinopathy. So on to you, Dr. Shivani. Can we have the slides here, please?
Good morning everyone. The title of my presentation is Spot Urine Albumin is a biomarker for proliferative diabetic retinopathy. Raised spot urine albumin is an indicator of a potential kidney damage in diabetic retinopathy. Spot urine test is a simple, physician-friendly, easily available and a reliable test. Spectral domain optical coherence tomography is an accurate diagnostic instrument for defining the in vivo histology of the retina, and optical coherence tomography (OCTA) is an extension of the OCT which offers an imaging of the retinal vasculature. The aim of the study was to evaluate spot urine albumin levels as a biomarker for proliferative diabetic retinopathy and to correlate the stages of diabetic retinopathy with various OCT parameters depicting a neurovascular unit. Data collection was done, and this design is a tertiary care center based cross-sectional study. A total 104 sample was taken, total 78 cases and 26 controls. Spot urine albumin was measured, and SDOCT parameters like foveal avascular zone, superficial vessel density, deep vessel density, and OCT RNFL and OCT ganglion cell analysis were also examined. The sample size were divided into controls, no diabetic retinopathy, non-proliferative diabetic retinopathy and proliferative diabetic retinopathy. As we can see in this box and whiskers plot, the association of spot urine albumin and the stages of diabetic retinopathy, and we can see with the increasing pathology, there is a steep increase in the spot urine albumin levels. We can also see these OCTA parameters, where we can see that the foveal avascular zone is increasing, whereas the vessel density is decreasing with the increasing severity of the disease. In this, we can see that the thickness of the OCT RNFL is also decreasing, and ganglion cell analysis thickness is also decreasing with the severity of the disease. In the receiver operator curve analysis, we can see that the PDR is having an area under curve of 1, which is an excellent, so we can say that this is an excellent biomarker for predicting the proliferative diabetic retinopathy. So conclusion is, spot urine albumin is a novel biomarker for proliferative diabetic retinopathy. It predicts the progression from NPDR to PDR, and it correlates significantly with the superficial vessel density, deep vessel density, foveal avascular zone, RNFL and ganglion cell analysis on the OCT. Thank you.
Thank you, Dr. Shivani. So how frequently do you call the patients for follow-up?
Ma'am, it was a cross-sectional study. So first of all, when the patients came to us, they were like seeing if they are if they are fitting our inclusion-exclusion criteria. After that, we was taking the patient's measurements. First, if they were classified into their specific groups and they were examined, all the data was stored and analyzed retrospectively. They were not coming to us in follow-ups. It was a one-time study.
Okay, so for the future take-home message for all of us, how do you think we should monitor these patients? What do you get from your study?
The main purpose of my study was, as we all know, that India is the diabetic capital of the world, and the OCT machines and all these machines and the retina surgeons and specialists are not available everywhere. So in PSCs and CSCs, this is a very physician-friendly, economical and simple test to do. It can be done by anybody. We can train people for that, and we can see that if this patient is having diabetes and if this patient is having this much of spot urine albumin measurement, then in which grade this patient might come. So it will be easy for us to screen those patients and refer them to the centers where they can be given proper care.
Okay, that's excellent. Thank you, Dr. Shivani.
Thank you.
ये भूपेंद्र जी बाहर चले गए? Okay, so now we go on to our next presentation. This is by Dr. Dimple Thacker, and she'll be presenting on human retinol binding protein 4 as a novel biomarker for diabetic retinopathy. So, over to you, Dr. Dimple.
Thank you, ma'am. Good morning, everyone. So today I'll be presenting, the topic of my presentation today is human retinol binding protein 4 as a novel biomarker for diabetic retinopathy. So as we know that India ranks second in the global diabetic epidemic after China, and diabetic retinopathy is a microvascular disease which affects almost all the diabetics, and all the already known factors responsible for causing diabetic retinopathy in diabetics, like the poor glycemic control and the long duration of diabetes. Even after controlling these factors, it does not prevent the development of retinopathy in the diabetics. So this sparks the search for other key biomarkers which might contribute to its development. So HRBP4, or the retinol binding protein 4, could be one such rapid, cost-effective, patient-friendly blood-based biomarker which could serve the purpose of diagnosing the subclinical disease. Now, why HRBP4 and what it is exactly? The retinol binding protein 4 is a 21 kilodalton plasma protein which is a member of lipocalcin family, and it has got the main role in transporting the vitamin A or retinol to the eye and other tissues. But interestingly, it has recently been identified as a cardiometabolic risk factor, which is also responsible for regulating the insulin sensitivity, oxidative stress, inflammation, and lipid metabolism. Here's the structure of the RBP4 protein. So the well-known canonical functions of RBP4 is to transport vitamin A or retinol to the eye and other tissues. But the recently reported non-canonical functions of RBP4 are its role in impaired insulin responses. So these are the mechanisms by which it is responsible for insulin resistance. Like it has got role in the beta cell dysfunction. It causes inhibition of insulin signaling in the muscle. It also promotes gluconeogenesis. It has got endothelial mitochondrial dysfunction and oxidative, it has got role in these oxidative stress. It also promotes inflammation, and it also causes insulin resistance in the adipose tissue. So with this background, the aim of our study was to explore the role of HRBP4 in diabetic retinopathy among North Indian type 2 diabetic individuals. So it was a case control cross-sectional study. The cases were 45. They were type 2 diabetics with retinopathy, 45 controls without type 2 diabetics without retinopathy, and it was done at JNMC AMU. And individuals with type 1 diabetes, subjects with acute infection or inflammation, and individuals with macrovascular diseases were excluded from the study. After taking the fundus photographs of the patients, the retinopathy was graded according to the latest ETDRS guidelines, and the fundus photographs were taken using the VisuCam camera at Zeiss camera. Then 5 ml blood was collected from the patients following the full aseptic conditions. The blood was centrifuged, and the 3 ml serum was used for biochemical investigations, and 2 ml was stored at -20 degrees Celsius for HRBP4 estimation until it was analyzed. The analysis of the HRBP4 was done according to the guidelines given by the manufacturer of the kit, and it was performed by using ELISA, The kit was procured from Christian Biosystems, Mumbai, India. So coming to the results of our study, we could see no significant difference between the age groups of both age in both the groups. And HbA1c and fasting blood glucose were also similar in both the groups, suggesting that both the groups were suffering from diabetes. Then coming to the duration of the diabetes, postprandial blood glucose, urea, and creatinine. All of these showed significant difference between the groups, but they were high in both the groups, suggesting that the patients had poor glycemic control. Now coming to the relevant finding of our study, the mean HRBP4 level, it was higher, significantly higher in cases as compared to the controls. It was, we could see, okay, we don't have a marker. So we could see that in the cases, the HRBP4 level was around 96, while in the controls, it was around 56 microgram per ml. Now the ROC curve analysis of HRBP4 showed that RBP4 is a strong biomarker to distinguish between the diabetics and from the patients without diabetics. And this is the bubble plot which is depicting the relation of the RBP4 between the grades of diabetic retinopathy. Okay, sure. And so several studies have reported HRBP4 in various conditions like metabolic insulin resistance, metabolic syndrome, and other diseases. And the limitation of our study was the sample size was less to extrapolate it to the Indian population. So this pilot study demonstrated the significant elevation of RBP4 in North Indian patients, and the strong discriminatory power of RBP4 as a potential biomarker. Thank you.
So in a community-based scenario, how do you think we can monitor these levels?
So, ma'am,
you need a good lab, I think, for all this.
Exactly. So actually for the biomarkers to come into clinical use and practical use, it has to undergo various phases of tests until it is proven to be a good clinical biomarker which can be applied at the community level. So currently it is not come in that scenario. It is just the pilot study. The aim was to just show that whether it is raised or not in the retinopathy patients compared to those without retinopathy.
Okay, so I think it holds a promising future. Thank you, Dr. Dimple.
Thank you.
And now we have the fourth speaker on the list as of now, Dr. Anshika Bensla, and she'll be speaking on exploring systemic inflammatory markers correlation with OCTA changes in diabetic macular edema. And I would request all speakers to maintain their time, please. So on to you.
Good morning, everyone. I am Dr. Anshika. I will be exploring systemic inflammatory and hematological markers correlation with microvascular changes in diabetic macular edema, and this was an OCT-based clinical study which was done in Guru Nanak Eye Center. Okay, so as we all know, diabetic macular edema is a leading cause of vision loss in diabetic retinopathy, and it is a process driven by hyperglycemia, inflammation, and VEGF elevation. It is also known for thrombotic conditions, but the mechanisms on how it influences microvascular changes remain unclear. So the microvascular changes that we measure on OCTA were macular vessel density, phase area, circularity, and perimeter. And systemic markers that were measured were neutrophil to lymphocyte ratio, mean platelet volume, platelet distribution width, interleukin 6, and serum ferritin. Various studies have been done in the past, but they were all OCT-based study, which correlated CMT and hyperreflective foci in OCT. So, as we all know, these are very easily available inflammatory markers and known inflammatory markers. Our aims and objectives were to measure the systemic inflammatory and hematological markers in individuals with diabetic macular edema and to correlate these changes with OCTA findings. It was a cross-sectional study done over the duration of 1 year in treatment-naive NPDR patients with macular edema who were aged 40 to 70. After a detailed history of these patients were taken and other ocular diseases, other history of intraocular surgeries were ruled out, they underwent a general physical examination, and then after this, blood samples were drawn from these patients and sent for investigations to the lab on the same day. Patient underwent an ocular examination and were classified according to ETDRS classification, followed by OCT, which was done to measure the CMT because our inclusion criteria was to include only the patients who had CMT more than 300 microns, followed by OCTA. And on OCTA, we measured the vessel density and FZ area, perimeter, and circularity to assess the microvascular changes. These are the slides depicting how OCTA was done in various patients. So coming on to the results, so we had 30 DME patients. Out of these, severe NPDR were 60%, 36%, almost 36% were moderate, and 3% patient had mild NPDR. HbA1c was increased in 29 out of 30 patients, and macular VD was distorted and decreased in 93% of the patients. FZ area and perimeter were increased in 86%, and circularity was distorted in 63% of these patients. The systemic markers were as follows. Neutrophil to lymphocyte ratio, which is a known systemic inflammatory marker, was increased in 30 out of 30 patients. Mean platelet volume and platelet distribution width had similar results, increase in 22 and 21 patients. And serum ferritin and interleukin-6, interestingly, did not show an increase in majority of the patients. However, IL-6 was significantly increased in 14 out of 30 patients. So the correlation analysis were done. We did a quantitative analysis between NLR and macular VD, which showed a negative significant correlation with macular VD. And on a qualitative analysis, we can see that most of the patients who had a decreased macular VD had an increased mean platelet volume, and this relation was significant. Similarly with platelet distribution width. With foveal avascular zone, we had a significant correlation with neutrophil to lymphocyte ratio and mean platelet volume. And FZ perimeter had a significant correlation, not a significant correlation, but it was still a positive correlation with neutrophil to lymphocyte ratio. However, the correlation with mean platelet volume was quite significant. With FZ circularity, so the circularity was distorted in most of the patients who had an increased platelet distribution width. So this is the gist of it. Neutrophil to lymphocyte ratio had a negative correlation with macular VD and a positive correlation with FZ area and perimeter. Mean platelet volume had a positive correlation with macular VD, FZ area and perimeter. Platelet distribution width had a positive correlation with macular VD and a reduced FZ circularity, that is fast circularity was distorted in patients with increased platelet distribution width. IL-6 and serum ferritin were not showing any statistically significant in our study. So systemic inflammation, we all know, is closely linked to diabetic retinopathy and eventually leads to fluid accumulation and diabetic macular edema by blood retinal barrier breakdown. Neutrophils adhere to the cell wall, and this is reflected by a decrease in vessel density in the patient with increased neutrophil to lymphocyte ratio. Platelets, the platelet function is altered in diabetes. It is a known prothrombotic state, as we all know, and because of increased beta thrombin, there is more vascular complication, which is reflected by increased MPV and PDW. And IL-6 and serum ferritin, there have been many studies that have shown that IL-6 and serum ferritin are significantly increased. However, we did not find any significant increase in serum ferritin. It was normal in 29 out of 30 patients, but IL-6 was increased in 14 patients, still significant, but our study did have its own limitations. It was a small study, and some oral hypoglycemic agents also have anti-inflammatory effects. Systemic inflammatory markers, they can be markers for ongoing microvascular injury and can serve for markers for monitoring diabetic macular edema and its progression in centers where OCTA is not easily available. Thank you.
Thank you so much. So my understanding is that you do these inflammatory markers in patients who already have diabetic retinopathy findings, or even with pre-diabetic retinopathy findings.
Ma'am, already diagnosed cases of diabetic retinopathy with clinically significant macular edema, because OCTA is not available everywhere. So the progression can just be monitored by using these markers.
Okay.
Whether it is progressing or not, because a microvascular level, we do not have OCTA and FA available in smaller centers.
And how, my question again to you is, how frequently do you monitor these markers, and how frequently do you call the patient for follow-up?
Ma'am, it can depend upon the stage of the diabetic retinopathy. In mild NPDR with no macular edema, we can just monitor them 6 monthly. And in patients who have clinically significant macular edema, we can monitor them 2 to 3 monthly based on the levels. If the levels are increased, then we can of course refer them to the higher center for further investigations.
Okay, thank you.
Thank you, ma'am.
professional on anyone's part to be so late, and that's not acceptable. We shouldn't keep that as a benchmark for future meetings. So lovely speaking to, lovely listening to the three of you speak, and all the best to all of you. And we hope that you make more presentations in the next meetings and present more scientific work. So thank you very much, and with this and with the permission of Dr. Vartika, we'll just wrap up this session. So good day to all of you.